by definition, UCL is usually going to be an overhead athlete unless it's a trauma, and younger patients usually. Not always, but that with the case study, that's what it will be, because that's what you're going to see 90% of the time. So this is like, okay, so when I took off a few points on some people's stuff early on, like in the first CPN, whenever you're dealing with the elbow, you have to look at the shoulder blade, and that's part of your plan. Because you have to figure out why it's causing that. We know that the UCL is torn from an MRI or a moving valgus stress test or a milking technique or whatever. But why is that happening? And there's a bunch of reasons. One, they play in sports year-round and just tensile failure, and they can't hold up. Two, they throw hard. You know, we know that kids that throw harder or professional athletes are more prone to it. But most of the time, it's a kinetic chain leak. It's either something up at the shoulder, the scapular stabilizers aren't decelerating the shoulder blade enough so that they can't control the descent of the arm, and you go into too much valgus, which puts stress on the UCL. Maybe their biceps isn't working the right way. Maybe their hips are doing what's called a catch-up phenomenon, where you go to throw and your arm lags behind. You're putting a lot of strain on the shoulder, your elbow drops down, and look what that position that puts you in. It puts you in a valgus. So you can't evaluate something at the elbow where it doesn't technically make sense why they injured it. There's reasons they injure it. ACLs, there's reasons that they're injured. All right, I call an ACL, a lot of people call it a deceleration injury. I call it a lack of deceleration injury, because you can't decelerate yourself enough, because your hips aren't strong enough, your quad isn't strong enough, whatever the reason is, and then your ligament takes too much of the brunt. It's the same thing with the UCL. So you've got to incorporate hip strength, you've got to incorporate scapular stability, you've got to make sure that all the mechanics around the shoulder are good, so that you don't end up fixing this thing surgically, rehabbing it the best way. They come back, they pass all your functional tests. Well, if they don't pass all the other stuff, then I don't want them to go back. And I told them that ahead of time. So you've got to make sure their shoulder is good enough. You've got to make sure their hips are good enough. Make sure their scapula is good enough. So that's going to have to be at least mentioned at some point in the practical, all right? So you want to look at like a sleeper stretch. You know, you want to look at a pec minor tightness. You want to look at the shoulder blades. That would be the first thing I do, along with like single leg stance and single leg squat, to make sure they're not flying in at that knee so they don't have hip control. And I tell them why. And once you explain it why, they're like, oh, it just makes sense if you explain it the right way, all right? So, kind of the observation first. I'd consider looking at the shoulder blade, active shoulder range of motion, single leg stance, single leg squat. I would consider that more observation for the elbow, even though it's active range of motion from the shoulder, if that makes sense. So that's the stuff I would kind of do first, okay? This is non-surgical UCL, so not a repair, all right? So then you kind of think, okay, I looked at where the kinetic chain's at. I'm seeing if there's a leak anywhere. I'm seeing what's going on there. I've got that in my head. I'm writing down maybe any ideas I have for treatment right there. Bring a pad and a paper, just because you might want to write some stuff down. That's fine. And then I'm going to go to the elbow. So now we're done with the observation phase. And what are you going to look at first? What do we look at first in the shoulder? Active range of motion. So you want to do active range of motions. You want to see how it moves. It's the least aggressive way to see how they're moving. They can control it, so they're not going to go any farther than they want to go, rather than you grabbing it and pushing it farther than they want to go. So it's always easier to just have them do active range of motion first. Watch their face, see if they're in pain, see if they deviate anyway whenever you're doing any kind of active range of motion. So you just want to do flexion a couple times. Just tell them, bring your elbows up. I usually have them do both at the same time, just to kind of see what's going on, because they're going to have soft tissue approximation, and you want to see if it comes short of that or not. I would do flexion. I would do pronation, supination at the elbow, just to see what the range, because you don't know this is a UCL. I mean, theoretically, you'll have it in there for the practical, you'll kind of know, or I might not even write it in I probably won't write it in the practical. I'll just tell you during the practical that, okay, you're doing the active range of motion. Let's say we suspect a UCL tear. All right, what would you do then? Okay, so I'd let you maybe get through the active range of motion and that kind of stuff, and then we'll tell you where you're at. So your passive range of motion, you're still looking at the same kind of stuff. Does it match your active? Okay, most of the time in the elbow, you're not going to have big differences in active and passive range of motion. It's almost always a tightness issue, okay, if there's one there. Or pain. If it's super painful, then you're going to have differences. But almost always, because it's a hinge joint, you're not going to have the freedoms up in the shoulder. You don't usually tear. You know, if you tear the biceps, you still probably can get full elbow flexion. So it's just there's other muscles that do it. So we did the active range of motion. We assessed, you know, stuff. You asked them the questions, obviously, like we did in the shoulder. I didn't go over that, but you know what your mechanism of injury is. You need to know maybe how much they pitch, how many leagues they're in. Just look that up. I think I listed it on the presentation. Make sure we should be screening this. You know, make sure it's not a red flag. Nothing crazy stupid. All right. If they had a severe trauma, you want to make sure they had an X-ray, just to make sure you're not dealing with an occult fracture or something. All the kind of normal stuff you're going to do in the subjective. So you did your active range of motion. You might want to look at the wrist. Okay, just because there's pain on the inside of the elbow doesn't mean it's UCL. Okay, could be medial epicondylosis. Okay, could be a flexor group tendonitis. I mean, so there's a lot of different things that can cause pain in that area. All right, so you want to clear the shoulder. You want to clear the neck. You need to do both here because there's nerves that run down. So that could be from the neck. All right, we'll go over that on Monday, but I'm not going to hold you too crazy to the clearing stuff. All right, we'll get to that. You want to palpate for sure around the elbow. So make sure you know where your palpation is. I'm not going to, you know, if you're really close, it's fine. I'm not going to, you know what's more on top, next down, what attaches to the epicondyle, where you would see pain with ulnar collateral ligament, where you would see pain with medial epicondylosis, those kind of things. All right, because you do, palpation around the elbow is important, probably a lot, well, it is a lot more than the shoulder. Okay, and then we'll go to special testing, and you know, if there's a limited range of motion, then I might have you do a joint mold, but I'm not going to be too specific with that. So maybe like a scoop technique, like we talked about, the distraction, something easy like that. I'm not going to get super specific with radial ulnar molds and that kind of stuff, all right? And then talk a little bit about treatment. You don't need to worry about post-op stuff. I'm not going to do a UCL post-op patient, but you would want to talk about proximal stability before distal mobility, all right? So you want to, before you let them do anything distal, you're going to want to make sure the scapula is good, the hips are good. That's something you can start on right away, no matter how much pain they're in usually. You can find a way to strengthen those things without aggravating the elbow. Okay? Home exercises at home. Obviously, what would be the first thing you would want to address? Easiest thing, we did it with the shoulder. Yeah. Did you raise your hand? What do you get to guess now?
I was going to say range of motion.
Yeah, range of motion. Yeah. You need to have the joint moving before you strengthen it. The last thing you want to do is have a tight joint and try to strengthen through a very limited range. It just doesn't make sense. Unless there's some crazy extraordinary circumstances, which every now and then there is, but not very often. So you almost always want to concentrate more on getting full range of motion early on. So any range of motion deficits they have, even if it's not a true soft tissue thing, and you think it's more an open end feel and pain driven, you still want to get them used to moving and trying to kind of tickle into that resistance or that pain area just a little bit and then come back out. We're not staying there a long time. If it's pain dominated, what type of grade molds would you use?
1 to 2?
Yeah, low 1 and 2 maybe. Maybe you'll see pluses and minuses. You know, 3 minus is just a low level grade 3. You know, 3 plus is you're getting close to a 4 and you're pushed into the resistance pretty good. So you know, that's something that might come up in some of these, probably not all of them, but some. So you want to tell me whatever grade you're going to use with the joint load, and that would just be to restore motion, or like just the distraction. If you think it's joint related pain, you could distract that elbow. Right, it never hurts. Got a patient in right now that is a patient of one of my other colleagues that's on vacation. She had a medial meniscectomy, and she gets a ton of relief just from distracting the knee joint. So, and her range of motion is pretty good, but pain relief gets relief just by doing distraction with the knee. So, and you can't go wrong very often with distraction. Now, if it's a true UCL, you don't want to distract it too much, because you know you're going to be lengthening that ligament a little bit, especially if it causes pain. Most of the time it doesn't. Most of the time, any type of valgus stress test, weight bearing, things like that open up that medial joint line and stretch that UCL are what's going to cause pain. Almost always. So home exercise or exercise you're going to give them there would be range of motion exercises. I would probably start, if it was a thrower, I would probably start with more scat stave stuff and hip stuff if I saw that it was weak. Okay? Make sense? All right, questions on that one? It's a tough one. UCLs are tough. I mean, it's just not as, I don't know, clear, I guess, as some of the shoulder stuff in my opinion. But